Continuing part 2 on malignant hyperthermia. Aside from increased energy, it does lead to an increase of oxygen consumption and heat production. The first unexplained sign is tachycardia. When your heart rate is over 100 beats per minute, it can cause a heart attack or stroke. Patients will present with unexplained rise in end-tidal carbon dioxide, which is the maximum concentration of exhaled breathing. It is estimated that 1 in 50,000 adults and 1 in 15,000 children are susceptible. If left untreated, patients will develop numerous metabolic abnormalities, rhabdomyolysis, which is a muscle cell breakdown, or respiratory acidosis, when your lungs cannot remove enough of the carbon dioxide produced and caused within our blood and body fluids, and it becomes too acidic, or myoglobinuria, which is when your kidney levels of myoglobin is too high and it can cause damage to your kidneys. And there are really many other cardiac and vascular abnormalities. A patient's mortality rate is nearly 80%, and a patient can die within 15 minutes once triggered. The most common anesthetic gas that causes MH is succinylcholine and all inhalation anesthetics except for nitrous oxide. Again, MH is rare, but it is important for us to understand and to assist if needed. When a patient is identified preoperatively that they are susceptible to MH, the anesthesia team will change breathing circuits or machines to clear out all lines, tubes of any possible inhalation trace. A new anesthesia machine or circuit is then flushed with oxygen for at least 20 minutes. We also will remove all vaporizers from the machine to avoid any accidental administering, along with not using succinylcholine with general anesthesia. Malignant hyperthermia treatment or the protocol. Once MH has been identified, we immediately stop the procedure and, if possible, stop all triggering agents and ventilate with 100% oxygen. Anesthesia is calling for someone to retrieve the MH cart, always one in every OR. Meanwhile, anesthesia is administering dantrolene through the IV, which is a skeletal muscle relaxant specifically developed to treat MH. Remember, as this is happening, the patient's muscles are contracting, which leads to destruction of that patient's muscle cells. When this happens, the destroyed cells cause many substances to release in the body, such as large amounts of potassium, which leads to hyperkalemia, high potassium level in your blood, a chemical that is critical to the function of nerve and muscle cells, including our heart. So when this happens, we need to treat immediately with sodium bicarbonate, or sodium bicarb for short, diuretics to eliminate excessive potassium, and also insulin, which can help reduce potassium in our blood. A team member or someone assisting is also applying ice packs to the groin, neck, and axilla, areas with large blood vessels, to rapidly reduce the patient's temperature to prevent brain damage. The surgical team is also irrigating with cold saline to help cool the core body temperature. The circulator is inserting a Foley catheter if one is not already placed to monitor urine output and kidney function. Once it is controlled, if the surgery is elective, it is discontinued. If the surgery is to treat a life-threatening condition, then we do resume with different anesthetic agents and a different anesthesia machine. Afterwards, we do need to remember to restock the MH cart and to review the hospital policy for the MH crisis. A good acronym for MH treatment is on page 227, Make It Simple box. How do surgical technologists do it? HDSTDI. H, hyperventilate. D, dantrolene. S, sodium bicarb. T, temperature management. D, diuretics. And I, insulin. Items that you can find in the MH cart include dantrolene, Rhinodex, which is the new formation of dantrolene, sterile water to help reconstitute the dantrolene, sodium bicarb, lidocaine, syringes, IV catheters, temperature probes, sterile drapes, a catheter, and bags for ice with a bucket. Visit www.mhaus.org for more information on malignant hyperthermia.